Welcome back to Health Watch In-Depth, presented by UMass Memorial Healthcare. Joining me now are two well-known experts on joint replacement, and as we're going over the whole process, I wanted to start with both of you, and you can introduce yourselves and your areas of expertise, and when you would most likely see a patient and what symptoms they might present. So we'll begin with you, closest to me.
Great. So I'm Dr. Katherine Upchurch. I'm the clinical chief of the Division of Rheumatology at UMass Memorial Healthcare. As a rheumatologist, I specialize in the medical management of patients with all sorts of joint pain. Particularly today, we're generally focusing on osteoarthritis, which is wear and tear arthritis. So pain is the symptom that ordinarily brings a patient in to see me. And my role is to explain to the patient all the different treatment strategies I can think of to keep the patient away from the surgeon. Okay. That is, to produce a very comprehensive program of strategies to try to minimize their pain. But then a very important role I have is to get to know the patient, work with them, and help them understand when they're ready for a joint replacement.
Okay, let's turn it over to you, Dr. Baima.
And I'm Dr. Jennifer Baima. I'm a physiatrist at UMass, and my role is helping patients with exercise recommendations for their joint pain.
Okay. So if someone comes in and they're having pain, they might say, that's it, I've heard knee replacement is the way to go, or joint replacement in other areas of the body. What do you typically tell them? Where should they begin to manage the pain before they have to make a decision, as you mentioned, towards surgery?
Well, what we emphasize are several different approaches. The first approach is basically non-medical or non-pharmacological. So conservative management, for example, would include weight reduction in patients who are overweight, which is a very common associated risk factor. Other non-medical or non-pharmacological approaches would be things like strengthening of the muscles above the knee, and I know Dr. Baima will be talking about that. Maybe you can chime in and say what you would be doing there.
Yeah, absolutely. I think so many patients are afraid to exercise when they have pain. So I think one of the things we first do is say, okay, this is safe and this is not safe. This is what you should be thinking about, and this is what you shouldn't know. A question I get a lot of times is, does running cause this problem? And there's actually no evidence that running causes osteoarthritis. However, if you have a swollen knee, you should not be running on that knee. So a lot of times we're examining the individual patient and deciding what's best for them in that situation. It really depends not only on their symptoms, but also on their radiographic findings and what they've tried and what their activity level is before the surgery. For example, an overweight patient who is focusing on weight loss may have a different time than, a young marathon runner who's having some joint pain symptoms. So we have to consider all of their risk factors and their lifestyle choices when we're making these recommendations. Another question that I get a lot is, what if it hurts too much to exercise on land? And that happens, so a lot of times we'll put the patients in water. So aquatic physical therapy is actually an option for this, and I do find a lot of patients get relief with this. I know the American College of Rheumatology recommends exercise for this, so it's part of both of our treatments, I think.
Is this a good idea, even if someone is going down the road to surgery, to do the exercise regimen to add strength?
Absolutely. So we know that exercise helps with your heart, your lungs, and your bone density. So not only does it help to strengthen the muscles around the area, which are going to be compromised with any kind of surgery, it helps with your bone density, it helps with your heart and lungs. It probably decreases the risk of the surgery itself. So we do always recommend exercise. I think the trick is finding an exercise the patient can do without pain. And a lot of times we'll enlist the help of our excellent physical therapists here at UMass. Our physical therapy department is located at Hanneman, and they're very good at helping strategize with this. And if the patient has trouble with the land-based strengthening exercises, we'll switch them over to water. So usually there's a way around the problem. We just have to find it, and we try to tailor that to the individual patient and their needs.
Okay. Dr. Upchurch, are you finding similar questions or fears that people are coming in with this joint pain, that they have been sitting around thinking, maybe the swelling, maybe the pain will go away if I do nothing?
Right. Well, actually, we can refer to the medical literature. Years ago, there was a study in which two groups of patients were studied. One group was a control group that did not pursue any activity. Another group, as I described them, I described Group A as couch potatoes when I discuss it with my patients, and the other group were randomized to the exercise group. And even though we don't have the capability yet in the area of current state of medicine to change the course of osteoarthritis, what we can do is improve symptoms, and the couch potatoes didn't do as well as the patients who actually pursued a graded exercise program. So there's data to support this, and I'm sure that's the same in your field. And the second point is that the orthopedic surgeons really hope to regain function in addition to improving pain. So the most function that the patient can have, the more function that the patient can have, the better. So we would encourage patients to be able to extend their knee as fully as possible and to try to flex their knee as much as possible as well before the surgery, which will make the outcome of the surgery potentially better.
Are certain people, even if they're not overweight, but are some people more prone to these conditions, the way that they're built?
Well, I think some people are born with certain abnormalities that lead to osteoarthritis. For example, people who are born with congenital hip disease, we know, will go on often to develop osteoarthritis prematurely. There are certain genetic diseases that are associated with osteoarthritis, and we know even in a less well-defined way that there are families who have genetic factors that lead to osteoarthritis. In general, though, I think injuries earlier on lead to later in life osteoarthritis. I tell people that if they played basketball for the Celtics, there's about a 100% chance that they would be seeing Dr. Ayers or other orthopedic surgeons at some time in their life. So injuries, previous sports injuries, are a major cause of osteoarthritis down the road. So there's a wide array of osteoarthritis etiologies in the weight-bearing joints.
Is there anything you can do to prevent it so someone doesn't even have to get to the point to see either of you?
Well, I think avoidance of major risk factors such as being significantly overweight may be helpful.
Okay.
I think that's a known risk factor. Trying to avoid certain occupations that may be associated with an increased incidence. I agree that there's no firm data that jogging, as odd as it might sound, which is a pounding exercise, there's no data to support the fact that it causes osteoarthritis. I think maintaining muscle tone is as good a preventive strategy as you can do. Sadly, though, we really don't know enough about the biology of osteoarthritis to be able to prevent it yet, but we're getting closer.
Okay. Dr. Baima, I see you
And
shaking
I think
your
that
head.
can be a very frustrating thing for patients. So many times patients come in and they say, what medicine can I take to prevent this? And gosh, don't we wish we had something that was the case. But I think, we do know that obesity is associated and is a risk factor, and we do know that exercise helps for obesity. So we want to, when we're developing an exercise program, it's always helpful to consider strength training and aerobic exercise because we want to protect our bone health as well as lose weight. And I think it's very hard to lose weight by just restricting calories. Some people can do it and some people do it very well, but I think that combination of restricting calories as well as increasing your exercise really makes the difference in weight loss. And I think that's one way that we can take control and really at least treat the symptoms, if not prevent osteoarthritis. And we know from the rheumatologic literature that actually moderate exercise is helpful for symptomatic osteoarthritis. It doesn't prevent it. It doesn't, if this is in your family and this is something that you're going to get, this is unfortunately what's going to happen. But in terms of feeling better and having less joint pain, if you exercise, it is very likely that will be the case.
Okay. When do you get to the point, and this can be, we'll just go left to right, my left to right on this, when do you get to the point that someone has to have surgery or recommend surgery?
Well, let me add a couple of steps
Sure.
between conservative management and surgery.
Absolutely.
So we pursue a treatment with analgesics such as Tylenol. Uncommonly, we try now particularly to avoid very strong pain-relieving medications for a variety of reasons, but there are some that are weaker that can be very helpful. The second thing we often do is use nonsteroidal anti-inflammatory drugs judiciously with caution about risk factors and that sort of thing. We inject joints with corticosteroids, which do provide some symptomatic benefit sometimes and often show us some surprises. Occasionally we'll find Lyme disease that we didn't expect or gout that we didn't expect or related conditions, but that can be very temporizing too. And then there's a bit of a debate going on right now about whether injecting very viscous substances that are ultrafiltrates of joint fluid are helpful. I think the jury's not completely in on that one yet, but that has been a strategy that's been used quite a bit. And then one final thing I wanted to mention is the glucosamine myth. Glucosamine is a product that can be bought over the counter without a prescription, and it's not an FDA-approved strategy. And there actually have been some very good scientific studies, one of which was engineered by the National Institutes of Health, and one of which just recently came out in the last month, that suggest or pretty corroborate the fact that glucosamine really doesn't change the course of this problem. I still tell patients if they want to try it, I don't have a problem with it because they may be in the placebo group and they may get benefit. But I also emphasize that in older people on fixed incomes, it's expensive. So if they do try it, there has to be a very concise pre-treatment understanding of the degree of pain and an endpoint. And if they don't get beyond that relief of pain by that endpoint, time out.
Okay. How about you?
So my focus is exercise, as you've already heard. So usually what I'm trying to do is figure out where that arthritis is and how we can get around it for strength training. So for example, when we send patients for a knee replacement, it's for the weight-bearing surface of the knee. So it's where the thigh bone meets the shin bone is the area that's being treated with that type of surgery. You keep your native kneecap, and I'm sure we're going to hear more about that. But for the arthritis under the kneecap, that actually responds very well to exercise treatment. However, when you have arthritis under the kneecap, it can be very painful to do squats. So sometimes patients say, gosh, I'm going to get and lose that weight, and it's January 1st, and I'm going to have a New Year's resolution to get in the gym. And my personal trainer told me I need to do 200 squats by noon, and then the knee pain acts up. And we can actually treat that by backing off on squats and doing another type of exercise. So it's usually figuring out, okay, where is your arthritis? Where is your pain? And what exercises can we do to make you feel better? And sometimes I'm recommending an independent exercise program. Very often I'm putting the patient with a physical therapist so they can learn a tailored exercise program that treats their needs.
Okay. You wanted to jump in there?
Well, I did. I think coming back to your original question, when and how do we determine or work with a patient to help them determine when a knee replacement might be in the cards? Well, first we have to recognize that they have advanced disease, and that disease would be advanced particularly symptomatically, because sometimes the x-rays don't show as much disease as the patient feels, and sometimes the surgeon goes in and sees much more disease than we can see with our imaging techniques. But I basically ask the patient to answer the following question. When you wake up in the morning, if you think about your day and what you'd like to do during your day, are you limited by your pain? Do you have to change your degree of activity, how you want to spend your time, and do you have to significantly modify your lifestyle because of your knee pain? And that is actually a pretty straightforward question. Most people can answer it. And when they start to think about it and realize that every day their knee pain plays an important role in structuring what they do and what they can't do, they realize that they're getting pretty close. And then it becomes a question of whether they psychologically are ready to undergo what is by all definitions a major procedure with a major potential for rehab and that sort of thing. But I think most people, when they realize that their joint pain is strikingly modifying the quality of their life and the promise of improvement, they come around and realize that they're excited about this and they're ready to jump in. But there is a process, and it does require knowing the patient and answering back to the patient or listening to the patient and telling them what you're hearing.
Okay. Very good advice, very good questions, and we have a lot more information coming up. You two have been great, so thank you. And as we said, we have a lot more information straight ahead. We'll see you back here after the break.